about to begin.
This hearing will come to order. As the hearing is fully virtual, we need to address a few of the housekeeping matters. For today's meeting, the chair or staff designated by the chair may mute participants' microphones when they are not under recognition for the purposes of eliminating inadvertent background noise. Members are responsible for muting and unmuting themselves. If I notice that you have not unmuted yourself, I will ask you if you would like the staff to unmute you. If you indicate approval by nodding, staff will unmute your microphone. I remind all members and witnesses that the 5-minute clock will apply. If there is a technology issue, we will move to the next member until the issue is resolved, and you will retain the balance of your time. You will notice a clock on your screen that will show how much time is remaining. At 1 minute remaining, the clock will turn to yellow. At 30 seconds remaining, I will gently tap the gavel to remind members that their time is almost expired. When your time has expired, the clock will turn red, and I will begin to recognize the next member. In terms of the speaking order, we will begin with the chair and ranking member, then members present at the time the hearing is called to order will be recognized in order of seniority. And finally, members not present at the time the hearing is called to order. Finally, House rules require me to remind you that we have to set up an email address to which members can send anything they wish to submit in writing at any of our hearings or markups. That email address has been provided in advance to your staff. Okay. With that, I want to acknowledge Ranking Member Congressman Cole and all of our colleagues for joining us today. Before I begin, I would just like to take a moment to recognize that today is March 11th. It marks exactly 1 year since the World Health Organization declared COVID-19 a global pandemic. Since that day 1 year ago, almost every aspect of American life has changed. Our economy has floundered, cities have shut down, thousands of businesses have closed, rates of food insecurity and poverty have grown, and more than 525,000 Americans have lost their lives. And with each passing day, the wide-ranging, enduring consequences of this terrible catastrophe are becoming horribly and more devastatingly clear. For example, not too long ago, an 11-year-old girl came into the Connecticut Children's Emergency Department. She was there for something unrelated to mental health. But recently, the hospital had made it a policy to give all patients as young as 10 years old a universal suicide screening. When doctors asked the girl if she had any thoughts about killing herself in the past few weeks, she said yes. She said she had been thinking about suicide for quite some time, but did not know who to talk to about it. Her mother was shocked. The issue of mental health and substance use was already a growing concern in this country before the COVID-19 pandemic. But the isolation, the school closure, the economic anxiety, and challenges to obtaining childcare have only exacerbated these already existing problems and created new barriers to treatment. In 2019, 1 in 10 adults reported symptoms of anxiety or depression. In 2020, that number increased to 4 in 10. Some surveys have shown over 50% of people reporting that the pandemic has negatively impacted their mental health. And it is our nation's most vulnerable who are the most at risk. According to data published in the official journal of the American Academy of Pediatrics, suicidal thinking among young patients is up 25% or more from similar periods in 2019. Another CDC report found that in 2020, pediatric emergency admissions for mental health problems like anxiety and panic have increased by 24% for young children, 31% for adolescents compared to 2019. In addition to our nation's children, this pandemic has been especially difficult for minorities, young adults, and essential workers. Women with children are more likely to report symptoms of anxiety and/or depression than men with children. Black and Hispanic adults are more likely to report symptoms of anxiety or depression than white adults. Those who are essential workers are particularly affected. In addition to reporting symptoms of anxiety and depression during this pandemic, essential workers are also more likely to say they are starting or increasing substance abuse and have suicidal thoughts compared to non-essential workers. Finally, young adults are reporting higher than average levels of anxiety, depression, and substance use as a result of this pandemic. Certainly, the COVID-19 pandemic has been difficult for all of us, but it has been especially difficult for these groups, and it is leading to even greater problems like substance misuse, drug overdoses, and domestic violence. For example, there has been a double-digit increase in domestic violence hotline calls since the beginning of this pandemic. And the kids in those families are experiencing ongoing trauma without the respite and support they might previously have gained through school. Meanwhile, drug overdoses are up 42%. Overdose deaths are up 24% in 2020 compared to 2019. Alcohol sales and consumption have skyrocketed. And while it is too soon to know how the pandemic has affected suicide rates, we do know there have been considerable increases in the number of people who report thinking about committing suicide, just like that 11-year-old girl in my home state, Connecticut. But we are not sitting on the sidelines. For quite some time, we have been working to provide more funding and resources for mental health and behavioral health programs. We have, this committee has provided significant funds, and we've done this on a bipartisan basis, significant funds for the Substance Abuse and Mental Health Services Administration to address this emergency through the CARES Act, the December emergency bill, and the American Rescue Plan, which we passed yesterday. That includes additional funding for both the National Child Traumatic Stress Network and certified community behavioral health clinics. I look forward to President Biden signing the American Rescue Plan into law tomorrow so that these resources can get out the door to our communities. I also want to note that the Affordable Care Act was integral in expanding Medicaid, which in many states is the most significant source of coverage and funding for substance treatment. And working together with my colleagues on this committee, we have supported a number of investments to improve the mental health of children and young people. This includes a landmark new federal investment in social emotional learning, investments in the so-called whole child approaches to education, and investments in community schools. We have also invested in Project Aware and Healthy Transitions, which were part of the, quote, now is the time, end quote, initiative following the tragedy in Newtown, Connecticut. And I am particularly proud to say we have increased funding for the National Child Traumatic Stress Network by $25 million over the last 5 years, an increase of more than 50%. As part of the investment in the National Child Traumatic Stress Network, we also directed resources to provide counseling and trauma services to unaccompanied immigrant children. We need to do more. I also agree we must recognize these issues that do not exist in isolation from each other, which is why we created a new pilot program last year to help state and local health departments develop plans to address the social determinants of health in their communities. But while these investments are a step in the right direction, the behavioral health system has been underfunded for years. We need to be thinking on a more long-term scale, provide the funding, the resources needed not only to help weather the immediate effects of this pandemic, but also to help treat what I expect will become an exponentially increasing mental health crisis in the next few years. This simply is not something that is going to go away as soon as everyone gets a COVID-19 vaccine. Without proper treatment, trauma and complex trauma, like the kind we are seeing in so many kids and adults during this pandemic, can last and compound for years, even generations. Our kids, our essential workers, our most vulnerable, are suffering. We owe it not only to them, but to the health and resilience of our economy, our workforce, and our society to ensure these people get the mental as well as the physical health, the health care that they need. We are fortunate to have an incredible group of experts with us, and I look forward to hearing your recommendations on how to build a stronger behavioral health system that is capable of meeting those needs in the years to come. In many respects, you all seem to be in general agreement on the need for greater investments in the Substance Abuse Prevention and Treatment Block Grant and to expand the behavioral health workforce so that we can meet the demand for services. We look forward to hearing how you have responded to the crisis over the past year and what you see as our top priorities as we move forward. And let me, what I want to do now is to yield to our ranking member, and then we will go to the introductions of the panel. And with that, I yield to Congressman Cole.
Thank you very much, Madam Chair. I'd be remiss not to tell you I really like those glasses this morning. They're pretty sporty. They make a strong statement. I want to begin by thanking the chair for holding this important hearing today. Much attention has been given to the economic toll of the pandemic and the impact on physical health, and rightly so. However, we all know those are far from the only impacts. In fact, some of the more subtle effects are just being brought to light, and we may not know all of the consequences for years or even decades to come. However, the information that we have on some of these secondary impacts is concerning. Based on recent surveys, symptoms of anxiety and depression have increased considerably in our population. In addition, survey respondents also admitted having started or increased substance use to cope with stress or emotions related to the pandemic. Suicide is also increasing, particularly for adults aged 18 to 24 and for minority groups. Overdose deaths, which had just begun to show a small decline, have marked a reversal and are now on the rise again. Life expectancy is decreasing, reversing progress over generations. After a year of lockdowns, isolation, and physical distancing, the mental health impact is apparent. Families having financial distress are further burdened by feelings of exhaustion, frustration, and mental strain from coping for so long. Sadly, too many families are also dealing with the loss of a friend or a family member. Many children are deprived of the emotional support and social learning provided by in-person schooling. Compounding these issues is a lack of providers to address mental health and substance abuse. The United States continues to have a shortage of qualified providers, particularly for rural and other underserved areas. Addressing these problems is at the core of several programs in the jurisdiction of this subcommittee. In addition to our annual appropriations, the fifth coronavirus supplemental passed just 2 months ago included more than $4 billion in funding for these issues. Much of that funding is yet to reach local communities, but over the next few months should become available to address the rising rates of substance abuse and the need for mental health services. As states begin to reopen, businesses start the path of recovery, and schools resume in-person instruction, we can begin restoring some of the stability needed to return to normal. I'm encouraged by the continued efforts to vaccinate as many adults as possible, and the news that the timeline for widely available vaccine continues to shorten. We may be just a few short months away from having the necessary vaccine supply to meet all demand. Again, such an accomplishment speaks to the perseverance and resilience of the American spirit. I would like to extend a special welcome to Verna Faust from my home state of Oklahoma. Ms. Faust has worked in community mental health for over 30 years and runs one of the largest behavioral health and substance abuse facilities in the state with 26 locations across Oklahoma. As a certified community behavioral health clinic, Red Rock provides a range of services, including outpatient, crisis stabilization for adults and youth, substance use, residential treatment, prevention, and housing. Red Rock was recently recognized as one of the top workplaces in Oklahoma, and Newsweek ranked Red Rock as one of the best addiction treatment centers in the United States. I also want to thank the chair for taking such a bipartisan approach in this hearing cycle. I've enjoyed the panels put together, and I know members appreciate the ability to have input on the topics covered and the joint selection of witnesses. I've always said that we may not agree on everything, but the chair and I have always worked well together on the many areas where we have bipartisan agreement. And I appreciate her thoughtfulness and will always work with her on our shared priorities. With that, I want to thank all our witnesses for speaking today, and I yield back the balance of my time, Madam Chair.
I want to thank the ranking member about a comment, first of all, on my glasses. Thank you very much. What I need to do, because I'm in the office in the Capitol, I've got to get to work in putting some color into this effort here. So, but a work in progress, or it's not even started yet. But I do. I think this is. I think this is a critically important hearing, and I think we both thought when we listened to the hearing on public health infrastructure that we noticed the consistency of information from all of our witnesses. And I felt that same way in reading the testimony of our witnesses this morning, with the emphasis on mental health and what we should be doing. So looking forward to the testimony, recommendations, and how we proceed forward. So thank you. And with that, I am delighted to welcome Arthur Evans, Jr., PhD, Chief Executive Officer and Executive Vice President of the American Psychological Association. I want to note that at one point in his distinguished career, Dr. Evans served as the Deputy Commissioner for the Connecticut Department of Mental Health and Addiction Services. Mark Stringer, Director, Missouri Department of Mental Health, who also serves as immediate past President of the Board of Directors of the National Association of State Alcohol and Drug Abuse Directors. He brings 35 years of experience in the substance use disorder and mental health fields. Dr. Lisa Amaya Jackson, co-director, UCLA Duke University National Center for Child Traumatic Stress. Dr. Amaya Jackson also co-founded the Center for Child and Family Health in North Carolina, a tri-university community collaboration that provides state-of-the-art trauma treatment and prevention services and a statewide training curriculum to serve children exposed to traumatic events. This is a program that's very, very near and dear to my heart. And the ranking member knows that. I think we were able to provide some funds for this for our Native American youngsters, those who have experienced trauma and violence. But Dr. Amaya Jackson, I've worked closely with Dr. Stephen Marins at Yale Child Study for years to build this program, and it's wonderful to see how it has spread. I was also interested in your work with youngsters at the border, and I think now we need to be thinking about how we increase the opportunity for your services with youngsters at the border, since many, many more are coming these days. And the ranking member introduced Werner Faust, but I also want to say that pleased to have you as a witness in representing the community behavioral health clinics. And we have worked hard to match our community health centers with the behavioral centers. People, you know, in the Senate, like Senator Stabenow, Congresswoman Alma Adams, and others on both sides of the aisle, understand the benefit of coupling the community health centers with the behavioral health centers. So thank you all very much. I will remind the witnesses that the entirety of your written testimony will be entered into the record. And now, Dr. Evans, you are recognized for 5 minutes.
Chairwoman DeLauro, Ranking Member Cole, and members of the subcommittee, thank you for the opportunity to testify today. I'm Dr. Arthur C. Evans, and I'm the CEO of the American Psychological Association, and the nation's largest scientific and professional organization representing the discipline and profession of psychology, with over 122,000 members and affiliates who are clinicians researchers, consultants, and students. Just this morning, we released the results of our latest Stress in America survey, which shows that the pandemic has taken a particularly difficult toll on American psychological health. 67% of adults said that their sleep had been adversely affected by the pandemic. 61% of adults reported experiencing undesired weight gain or weight loss, with those who reported weight gain gaining an average of 29 pounds. The survey also showed that some groups have been particularly impacted. Essential workers are more than twice as likely to have been diagnosed with a mental health disorder during the pandemic. Nearly half of mothers who still have children home for remote learning reported that their mental health has worsened over the course of the pandemic. And 66% of African Americans and 65% of Hispanic adults said that they could have used more emotional support during the pandemic. Without a doubt, our nation is experiencing psychological trauma and distress. And we know from previous research that this will continue and that we will continue to have problems in the months and years to come. If we're going to effectively and equitably address the mental health impact of this pandemic, we must use an approach that is based on population health. For most of our nation's history, we have approached mental health treatment with a model that is passive, that is reactive, and doesn't take into consideration people's social context. There are multiple problems with this way of working. First of all, it assumes that people will proactively seek out treatment when the research consistently shows that people often do not reach out for help, and when they do, they often face a multitude of barriers. Second, this approach focuses primarily on individuals in crisis or with more severe mental illnesses, essentially ignoring people who are having milder and earlier symptoms when it would be much easier to intervene. Additionally, this model fails to consider the critical effects that communities, systems, and social determinants play in people's mental health. To address this, we must add prevention and early intervention strategies to the approach we take for mental health. We must move upstream and use the best available science and explore solutions at the community level to prevent unnecessary suffering. This population health model has proven instrumental in saving lives and also in having saved money. Recently, I co-authored an open letter to President Biden with a former colleague, Dr. Gary Belkin, who is the commissioner in New York City. And we talked about our experiences as commissioners, I in Philadelphia and he in New York City. During our tenures, in our letter, we talked about strategies that we employed, like making investments in evidence-based clinical care and making investments in more preventative and early intervention care, like enlisting educators, law enforcement officials, and employers, as well as staff and neighborhood anchors like churches, child care centers, and community centers, and train them to identify the people who are in need of mental health treatment. We implemented school-based services to reach children experiencing social and emotional problems much earlier and more consistently. We made self-care tools and screening available through public kiosks, community outreach events, and call centers. These preventative interventions, along with traditional clinical care, delivered results and mitigated the risk for people which would have required more intensive treatment later. For example, the creation of an enhanced day treatment program by our team resulted in a 36% drop in the city's use of crisis services. It's essential in both the short term and the long term that we take this kind of population health approach to address the growing prevalence of mental health challenges and promote mental wellness across the nation. In doing so, we can provide both safe and effective clinical care and reduce the risk of people developing more significant problems. I applaud the committee for examining the long-term mental health impacts, and I would urge you to support funding for future system that really prioritizes our mental health as a nation. Some of the recommendations we would make is that we need to continue to make investments in interventions that both address the social determinants of health and target federal resources to evidence-based disease prevention strategies. We need to continue to increase the substance use and mental health block grants that allow systems administrators to implement more prevention and early intervention strategies. We need to increase funding for programs critical to the mental health workforce, such as a graduate psychology education program and the behavioral health workforce education and training program. We need to increase funding for programs to strengthen school-based mental health services, including funding for programs like IDEA, Project Aware, and Title 4A.
Dr. Evans, I have to ask you to wrap up, okay?
Okay.
So
APA stands ready to work with you and address inequitable access to care and the ever worsening mental health impact of the pandemic. And I want to again thank you for this opportunity to testify today.
Thank you. Thank you very much. Mr. Stringer, you are recognized for 5 minutes.
Thank you. Chairwoman DeLauro, Ranking Member Cole, and members of the subcommittee, my name is Mark Stringer, and I'm Director of the Missouri Department of Mental Health. I also serve as Chair of the Public Policy Committee of the National Association of State Alcohol and Drug Abuse Directors, or NASADAD. I really appreciate the opportunity to testify before you today, and we'll be focusing on the impact of the pandemic on substance use and substance use disorder. Since COVID-19 was first identified in Missouri a year ago, we've seen some really troubling trends related to substance use and substance use disorders. For example, drug overdose deaths increased by 21% in the first 3 quarters of 2020 compared to the same 3 quarters in 2019. A particular concern is the disproportionate impact those overdose deaths are having in the Black community. While deaths among white people increased 16%, deaths among Black people increased 37%. A survey done by the Missouri Institute of Mental Health in August and September 2020 revealed increases in substance use since the beginning of the pandemic. For example, of those surveyed, 56% said they were drinking more alcohol than usual, 60% reported an increase in smoking, and a little over 60% indicated increased misuse of prescription drugs. These issues and others present distinct challenges. As a result, my department worked to develop a model of treatment called the Medication First model for people with opioid use disorders. This model removes barriers to evidence-based care being delivered in a prompt manner and ideally the same day that a person presents for treatment. Thanks to the quick action at SAMHSA and CMS, our department offered treatment providers the flexibility to deliver services using web-based video applications, email, text, and telephone. We also offered providers flexibility on certain paperwork requirements and timelines. In addition to actions at the state level, we received a lot of help from Congress. The December 2020 package and the COVID-19 relief package cleared by the House yesterday included critical investments in NASADAD's #1 priority, the Substance Abuse Prevention and Treatment Block Grant. The additional investments from Congress in the block grant allow agencies like mine to direct funds where they're needed most. Further, an investment in the block grant is an investment in much needed primary prevention. The block grant prevention set-aside is a critical component of our prevention system in Missouri and statewide, or countrywide. Moving forward, here are my recommendations. First, we still need support of this subcommittee. We're fighting an urgent and very steep uphill battle. As much as the generous federal grant dollars have helped, resources are still needed. Second, I recommend a transition over time from opioid or drug-specific resources to investing funds in the SAPT block grant. While we are incredibly grateful for our opioid-specific grants, like the state opioid response grant, states would benefit from more flexibility to address all substances of concern. This very subcommittee embraced this approach in FY19, and we hope it can be done again in FY 2022. Third, please ensure that federal funding for addiction flows through state alcohol and drug agencies. These agencies play a critical role in planning, overseeing, and implementing a coordinated and a comprehensive system of care and they promote effective and efficient systems through oversight and accountability. State alcohol and drug agencies like mine promote and ensure quality through standards of care and technical assistance to providers. Federal policies and programs that do not flow through or at least coordinate with the state agency run the risk of creating parallel, duplicative, or even contradictory publicly funded systems and approaches. Finally, please support and bolster the role of the Substance Abuse and Mental Health Services Administration, SAMHSA. We support maintaining investments in SAMHSA as the lead agency within HHS focused on substance use disorders. The nation benefits from a strong SAMHSA given the agency's longstanding leadership in the field. NASDAD appreciates the role of the Assistant Secretary for Mental Health and Substance Use and who promotes a unified approach across HHS. And we're particularly grateful for the leadership of the current Acting Assistant Secretary, Tom Coderre, whom I have known and respected for a long, long time. In the end, SAMHSA should be the default home of the substance use disorder discretionary grants and related programming. Thank you for this opportunity and look forward to your questions.
Thank you very much. Dr. Amaya Jackson, you are now recognized for 5 minutes. Thank you. Dr. Jackson?
Sorry, I was on mute.
It's okay, it's okay. I do it all the time. Please go ahead, you're recognized for 5 minutes.
Thank you. Chairwoman DeLauro, Ranking Member Cole, and members of the subcommittee, thank you for this opportunity to testify today regarding the mental health and substance use crises associated with the pandemic. My name is Dr. Lisa Maya Jackson. I'm a child and adolescent psychiatrist and co-director of the UCLA Duke University National Center for Child Traumatic Stress, the coordinating center for the National Child Traumatic Stress Network, also known as the NCTSN. And as you know, the NCTSN was created by Congress in 2000 to raise the standard of care and increase access to services for children and families in the U.S. who experience traumatic events. This premier federally funded child trauma initiative, administered by the Substance Abuse and Mental Health Services Administration, includes 116 current grantees and over 200 former grantees working in hospitals, universities, and community-based programs in 43 states and D.C. Americans living under prolonged threat of danger associated with this pandemic have reported emotional reactions that include anxiety, depression, grief, substance use, and thoughts of suicide. Disrupted feelings of safety are tragically exacerbated by death of a loved one, illness, intimate partner violence, child abuse, and poverty. For children with trauma histories, new loss and adversity can result in nightmares, outbursts, school challenges, and complicate trauma and grief reactions. Overburdened caregivers struggle to buffer the effects of our children's suffering. On behalf of the NCTSN, I will identify several stresses we are observing, highlight efforts to mitigate these, and offer priority recommendations. First, children and families are at increased risk for traumatic stress and loss. Over 500,000 pandemic-related deaths in the U.S. are overwhelming our bereaved families, unable to even observe their mourning rituals. Quarantine families risk increased conflict, while economic strain increases risk for substance use, neglect, and family violence. Next, racial and ethnic minority families are disproportionately impacted. COVID-19 compounds the impact of racial discrimination and systemic disparities in quality of and access to essential resources. Limited access to culturally and linguistically responsive mental health care, fear of institutional bias, and historical trauma create a troubling context for COVID-19 among these families. Third, our nation's schools are facing unprecedented challenges. School routines, milestones, and critical social and emotional learning have been disrupted. Students may lack access to trauma-informed, evidence-based mental health services, and it has been difficult to identify students experiencing child maltreatment or suicidal ideation. Many school personnel could also use staff wellness programming. Finally, the pandemic impacts child maltreatment risk and child welfare. Professionals believe abuse may be increasing, given children may be sheltering where abuse is occurring and not reported. Contact between children in placement and their families has been reduced, while services supporting parents seeking reunification has been disrupted. The NCTSN response to the traumatic impact of COVID-19 on children and families is focused on several key priorities. We are tracking the pandemic's impact on our NCTSN centers, including secondary traumatic stress among child-serving providers. we are bolstering NCTSN members' provision of trauma treatment, training, and other services, often through telehealth and virtual training. We are disseminating trauma-informed COVID-19 resources to caregivers and child-serving personnel and providing trauma-informed training and consultation to federal, state, and local organizations. And finally, we are documenting lessons learned and practice innovations, including those that should be maintained post-pandemic. While we await further evidence of the totality of mental health and substance use consequences of the pandemic, I will conclude with 6 recommendations. 1, ensure children and families have resources to meet basic needs essential for overall mental health, resilience, and violence prevention. 2, increase access to evidence-based, trauma-informed services for children and caregivers experiencing mental health and substance use challenges resulting from the complex interplay between the pandemic and other national crises and disasters. 3, support schools in implementing trauma-informed programs to address gaps in their education, development, and mental health through and post-pandemic. 4, support essential child-serving systems such as child welfare, juvenile justice, and the Unaccompanied Alien Children Program to implement trauma-informed practices and policies. 5, support research to delineate mental health, substance use, and traumatic stress consequences of the pandemic on children and identify effective interventions. And last, prioritize needs of at-risk youth, including racial and ethnic minorities, youth with disabilities, immigrants, LGBTQ persons, and those living in poverty. On behalf of the NCTSN, I would like to thank the subcommittee for your longstanding commitment to the needs of children and families who have experienced trauma. We stand ready to assist as we all work together to address mental health and substance use crises associated with this pandemic.
Thank you so much. And Ms. Faust, you are now recognized for 5 minutes.
Good morning, and thank you, Chairwoman DeLauro, Congressman Cole, and distinguished members for the opportunity to speak today. My name is Verna Faust. I'm the CEO of Red Rock Behavioral Health Services, a certified community behavioral health clinic in Oklahoma. For many years, I worked closely with the Oklahoma Department of Mental Health and Substance Abuse Services that plays a critical role in overseeing the public behavioral health system. One of the benefits of making federal funds, such as the Substance Abuse Prevention and Treatment Block Grant, available through this agency is that we develop relationships, they understand what we do, they offer technical assistance, and they hold us to very high quality standards. We are also grateful for SAMHSA's role as the lead federal agency for substance use and mental health disorders, and hope that ongoing COVID relief efforts further bolster SAMHSA's role in administering these critical service grants. Red Rock was one of the first agencies in 8 states to become a CCBHC under the Federal Planning and Demonstration Program in 2017. This program has been a lifeline for community treatment. Prior to this initiative, fee-for-service payment models did not cover the true cost of the services, nor provide the funding for the services that were truly needed. The proven success of the CCBHC has led Congress repeatedly extending the demonstration and appropriating over $1.5 billion for the expansion of the program since 2018. Today, there are 340 CCBHCs in 40 states, Washington, D.C., and Guam. The CCBHC model provides integrated care coordination for physical, mental health, and addiction treatment in an effort to move the needle on the fact that Americans with severe mental and addiction disorders die 10 to 25 years younger than the general population. However, the CCBHC model will end on September 30th, 2023 for states in the demonstration unless Congress extends the program. In my opinion, extending and supporting the CCBHC model to all 50 states and territories with funding well into the future to allow for growth and planning could be the single most significant factor in improving behavioral health care in our country. There's been a shortage of mental health professionals in the U.S. for many decades. The National Survey on Drug Use and Health has consistently shown that over half of adults and youth who need treatment do not receive it. While demand for care is rapidly growing, the number of mental health professionals is barely holding even. A 2016 report by the Health Resources and Services Administration projects a shortfall of 250,000 mental health professionals by 2025. The CCBHC model is a great start in mitigating this shortage. Another helpful strategy would be broader access to student loan repayment through HRSA by broadening this benefit to all CCBHCs regardless of geographic areas. Since COVID, the rate of young adults aged 18 through 24 that have seriously considered suicide in the last 30 days has increased from 10% in 2018 to over 25% in 2020. Before the pandemic, 1 in 10 adults reported symptoms of anxiety or depressive disorder. Today, it's 4 in 10. Included in the December 2020 COVID relief package was an investment of $1.65 billion for the Substance Abuse Prevention and Treatment Block Grant. These block grant dollars are vital, and we are very appreciative of the work this subcommittee has done to include supplemental funding for the block grant. A bright light during this pandemic has been Congress's approval of services to Medicare and Medicaid recipients through the use of telemedicine. I urge Congress to permanently allow the use of telemedicine, and that any further federal efforts to address the pandemic's long-term impacts will take into account the benefit of multi-year investments. In summation, the federal block grant to the state is critical to provide services to the vulnerable. The CCBHC model is transforming our system. It has resulted in improved access to care, high-quality treatment through the use of evidence-based practices, better staff training, enhanced care for veterans, and is saving lives through the coordination of mental and physical health care. We must quickly address the workforce shortages to keep up with the demand that's so desperately needed, and understand that COVID has had a significant and lasting impact on the mental health of Americans. Again, thank you for this opportunity.
Thank you very much. And I want to say thank you to all of our witnesses. Once again, I think it's striking that all 4 witnesses have not only identified the problems and very descriptive of what the issues are and what this pandemic has caused, but also, again, just really stunned at the consistency of the recommendations of how we should go forward and what are the kinds of things that we ought to be doing. And I would just say to you that your testimony is very valuable in having an impact on when we put together the appropriations bill of what are the directions that we should go in. And with that, let me just ask, I'll start the questioning and I'll just focus on children's mental health for a second. The impact that the pandemic has on everyone's mental health is stunning. As I said, let me focus on children. We have worked hard to improve mental health for young people, particularly in schools. But now these children are at home. Parents who are stressed and anxious, some cases they are experiencing trauma in the home, and they don't have the same access to teachers, coaches, counselors, friends, the entire support system that may have been there in the past. And particularly, we have children with special needs, I think, who are really suffering from the effects of the pandemic. Dr. Maya Jackson, because children are still developing, they are particularly vulnerable to the stressors of the pandemic. We know how important the early years are. Can you explain how these current events can impact a child's development, what we need to do to keep them healthy? I'm going to ask with a follow-up, what kind of long-term impact do you think this will have on this generation of children? What do you think are the longer-term needs for children and families after the pandemic is contained?
Thank you, Chairwoman. Children, I think we have to always remember, are not just little adults, and we have to understand their experiences of stress and trauma within a developmental framework. For example, they experience stressors of the pandemic in a different way than we do as adults. Challenges such as quarantine and social isolation can have significant developmental impact. And if you think about where they're supposed to get that in schools with their peers and interacting with their peers, that's a very important ways of moving their developmental progression forward. What are they doing now? Well, they're really turning to their cell phones, to social media, to gaming. They have much more increased vulnerability in that way to bullying, not just bullying, but they're having increased exposure to sexual material. This is reducing the quality and appropriateness of their social engagement. We are hearing about the broadcasting of suicide attempts and self-injury through the media and in the internet. So as we, think about these issues, we have to be recognizing that we are setting patterns into play that are going to probably continue long past, the ending of this pandemic. Our parents really need assistance. We need community programming. We need access to services as they look to ways to think about strategies to work with their children, to engage with them outside of the internet, to be involved with them when they're on the internet, to be looking at apps that are involved with education, thinking about time limits, things like that. I think the issues around structuring peer interactions, as we move towards a time when we're all going to be safe together, we have to be thinking of developmental-oriented activities. And to be honest, we're probably going to have to learn a little bit about how we interact again. We've been in isolation for a long time, and I think children are going to need some help, and they're going to need some structure and, really emphasis on no shaming, no blaming in the way they interact with each other and with their adults around them.
Do we have, in your view, the kinds of resources or the adequacy of the current structure to be able to deal with the short-term issues that you're talking about and the longer-term issues when the pandemic is contained? What you mentioned some of the things. Who are the best the best segment of is it organizations who can help out? Is it physicians, mental health physicians? What are the tools in which we can begin to deal short-term and long-term in your view?
So I think this is an issue of looking at everybody in the child serving system, from pediatricians, the schools, the mental health providers, the systems in child welfare, juvenile justice, schools, as I mentioned. And the criticalness of putting children back into the routines. We have our jobs, children have their routines. While they're at school and they're being educated, they need that social emotional learning to be able to move forward. But the thing is, they're going to be dealing with new traumas that have occurred, cumulative risk on past traumas that have occurred, and dealing with grief reactions and stressed out parents. What the NCTSN is doing is we are bringing together an initiative that will pull together national stakeholders, our NCTSN experts, to define the impact of the COVID-19 on children and families. We're looking for identifying some key challenges for longer term planning and generate recommendations for agency leaders, child serving systems, and policy makers. And we look forward to sharing our findings with you. I think that we have to be in this for the long haul. This is going to be very big. And the question of whether we have sufficient resources, I really question that. I feel like there are families who have not been known to the mental health system who will now need to be known to the mental health system. And one important thing I'll mention is that our parents who are very stressed, whether they're essential workers, unemployed workers, or remote workers who have been trying to multitask as they take care of their young children and their children who are in remote school. They've been heroes, but they're doing their best, but there's been lots of room for some neglect that they are endorsing in some surveys, and violence in the home. And they're going to need some support, and I think they're going to be carrying a lot of scars moving forward. Many of them are grief-related scars. Many of them are having not been able to provide for their family. And one point I will make that's been clear is that, when we, as in my therapist hat, we're seeing children, we often recognize that parents need help too. And just because a child has Medicaid, it doesn't mean a parent does too. So a parent can seek care for themselves, but if you're asking a parent to seek care so that they can be the best parent they can be to their child, they may not have access to Medicaid and the resources to do that.
Okay, thank you very, very much. And my time has expired. I would just say to Dr. Evans and Mr. Stringer, at some point in any of your comments, the issue of Medicaid and its expansion, I would love to get your thoughts on how that's helped to deal with the access to behavioral health care. With that, let me recognize the ranking member, Congressman Cole.
Thank you very much, Madam Chair. I too was struck by the consistency of the recommendations and frankly the consistent strong advice that we have sustained investment over time here to be able to deal with the problems. I want to quickly ask each of our witnesses in order, if they could just very quickly, because I have a limited amount of time, give us what you think the 2 or 3 greatest impacts of the pandemic in your respective fields have had, for good or ill. I mean, really places where we need to focus as a committee. And I'll start, if I may, Dr. Evans, with you.
Sure. Thank you, Congressman. Well, I think that the impacts are going to be widespread. I would really prioritize the number of people who are having their first episodes with mental health challenges. Prior to the pandemic, we had a problem in this nation, as I noted in my testimony, that there are too many people in our nation who experience mental health problems and don't access care until they're in crisis. And often when they're in crisis in many communities, it is still even hard and difficult to reach them. So I think we have to put a big emphasis on early identification, identifying people when it's much easier to treat them, when we can prevent them from having more difficulty, and put a lot of emphasis on that particular population.
Thank you. Ms. Faust, let me go to you next. Are you there? You may well be.
Sorry, I was on mute. I would say much of what Dr. Evans just said, and not to repeat his words, but as far as something good that's come out of the pandemic, I really want to say that I think telemedicine has been a godsend. I think we've learned how to do it really quickly. We know much better what works. It's incredible how some of the clients have embraced technology. We're seeing lower no-show rates with telemedicine, and I, again, would just ask if this be considered to be permanent in the future.
And for what it's worth, we hear a lot of that in a whole range of fields. It is clearly something we need to focus on from a regulatory standpoint. Let me go, if I may, next to Mr. Stringer, and if you would give us again your thoughts on the 1 or 2 or 3 greatest impacts the pandemic's had in the areas that you focus on.
Yeah, thanks for the question. You know, what this has done, and especially early on, has created conditions of isolation, certainly unemployment, difficulty accessing services, hopelessness. Those kinds of things are all enemies of recovery. And those kinds of things all create opportunities to take substances in order to feel better or to relieve the pain. And so, you know, those are the main factors, I think, that have contributed to this. The other one, of course, is the availability of drugs. The cartels, others always figure out a way to get the product in, no matter what the conditions, even in a pandemic. So that's, Ranking Member, that's probably the best I'm going to do with that one.
Yeah, okay, thank you very much. And Ms. Amaya Jackson, from your standpoint, particularly, I guess, focused on young people, you covered quite a bit of this, but again, 2 or 3 of the biggest impacts, for good or ill, that you've seen the pandemic had.
Yeah, I would say the traumatic nature and grief of the mental, particular on parents and providers is very significant. That reduces their capacity to do what they need to be able to do. And I would also say, a very, very significant impact on child serving systems, be they schools, mental health centers, hospitals, pediatricians, et cetera. Those are busting at the seams. We know people have stepped up in a major way to be providing, critical care. But when the pandemic is over, I think where they will be at and where the future need will be at is going to be a mismatch. And I think that's a very significant issue we have to face. And telehealth will be something that we have to consider. I think we need data on where virtual learning and telehealth has been helpful and where the role is for hybrid versus, as mechanisms that help access the services.
Well, I can certainly tell you in a state like mine, which, as Ms. Faust knows, is heavily rural, it's been absolutely critical for us to deal with the problems we've had. With that, Madam Chair, I've limited time. I'm going to disappear for just a minute. That's just because I'm going to go vote, and I'll be right back.
Okay, thank you.
Go back.
Congresswoman Roy Ballard.
Okay. Thank you, Madam Chair. Dr. Evans, I'd like to raise an issue that is extremely serious but gets very little attention. As co-chair of the Bipartisan Maternity Care Caucus, I'm very concerned about the impact COVID-19 has had on the mental health of expecting and new mothers. As you may know, maternal mental health, including postpartum depression and other mood and anxiety disorders, are the most common complications of pregnancy and childbirth. It affects 1 in 5 women, which translate into 800,000 new mothers each year in the United States. And tragically, suicide and overdose are the leading causes of maternal mortality for new mothers. Recent studies have shown pregnant women and new mothers are experiencing increased anxiety and depression during the pandemic at 3 to 4 times the rate prior to the pandemic. And women of color and women who live in poverty are disproportionately impacted by both maternal mental health conditions and the pandemic. Dr. Evans, could you please describe how maternal mental health issues differ from other mental health disorders, and if they require different approaches and therapies to address?
Sure. Thank you for that question. Yes, maternal mental health issues are different in some important ways that we have to take into consideration as we work with women. When I was commissioner for behavioral health in Philadelphia, I funded programs specifically for women who were going through their pregnancy. As you noted, postpartum depression is the most common complication within childbirth. One of the other distinguishing aspects of postpartum depression is that many of the women who are experiencing postpartum depression are experiencing it for the first time during childbirth, which means that they are not typically already connected to services. One of the things that I think is really important is that we have a multi-systemic approach to this issue. For one thing, we need to make sure that we have integrated within perinatal services mental health treatment, particularly screening and identifying women who might be at greater risk or maybe in the early stages of showing signs and symptoms of depression. I think we have to make sure that practitioners, both physical health practitioners, OBGYNs, and pediatricians are aware of the prevalence of postpartum depression and understand how to make connections to the mental health system. And we need to make sure that mental health providers understand the unique issues that women and mothers who are experiencing postpartum depression have. For example, the level of stigma and the issues around stigma are very different than the general population. You're already talking about a stigmatized condition, but it is particularly difficult for mothers who have elevated expectations about how they should be responding after childbirth. So I think that the most important thing is to make sure that we have the funding. When I funded those programs, there were some complications and particularly Medicaid funding around how many services or different types of services that you could bill for in a particular day. And so we had to do some very creative financing in order to fund those services. So I would put at the top of the priority list, making sure that we have good ways of funding those services and that we reduce those barriers so that those services are available to women during that process.
Dr. Evans, you touched a little bit on what my second question was going to be, and that is, how do we improve maternal mental health awareness, diagnosis, and treatment in this country to ensure that we get the best possible maternity outcomes for every mother, infant, and the family?
Well, I think that mental health treatment, early screening, early identification needs to be just a part of the standard of care. That no woman, in my view, should go through childbirth without the questions and screening around mental health and whether they're having mental health challenges. That is a systemic thing that we can do, but we also have to make sure, as I mentioned earlier, that practitioners, both physical health and mental health and behavioral health providers, understand the unique challenges that women face, that they have that education and they understand how to treat those women given the particular challenges that they're experiencing during childbirth.
Thank you. I see my time is up. I yield back.
Congressman Harris.
Thank you very much. Thank you, Madam Chair. I have a question direct, I guess, to Dr. Evans and Dr. Amaya Jackson. I'm a little worried about what the effect of the school closing will be and the isolation on youth violence. And let me just back up a little and say, look, what we see in adults and what we've heard is that, the fact that someone could infect you with a virus makes you distrust other people. They pose a physical risk to you, and whether you like to think it right away, when you pass someone on the street, you think, well, this person could actually adversely affect me. Is that percolating? Does that percolate down to children as well, as you remove them from school and they hear at home about all the, about the fact that, yes, that other person could infect me. They could, cause bad things to happen to my health or my parents' health. So does that percolate down, and is it different at different ages? So will this lack of the ability to associate with your peers in a friendly, non-threatening way, the lack of that, does it make a difference at different ages as to when this is all over? I mean, are our children going to go to school and go, wait a minute, I'm still afraid of that other person? And then what's the ramification of whether or not we see more youth violence because of this distrust? So I'll leave it at that and ask for your opinions. Dr. Evans, if you could start.
Sure. Well, I think the general point that you're making is a very important one, and that is that the pandemic is going to have long-lasting mental health impacts on people. We know that. Specifically how that will play out, we don't know. We don't have the studies. This is the first time in 100 years that we've experienced this, and we don't have the kind of long-term data that shows that. But the issues that you're raising, I think, are good ones. What we do know is that children have been under a significant amount of stress over a long period of time. And one of the things that distinguishes this pandemic from other kinds of natural disasters is the long, prolonged chronic stress level that we've documented in the survey that I talked about earlier, and others are documenting through other research. And what we know about that long chronic stress is that the impacts happen far after the crisis is gone. It's sort of like veterans who've been deployed for a long period of time. They actually adjust to the stress level, but when the stressors are removed, that's when you start to see some of the challenges. We suspect that that's probably going to happen with a lot of people in our population, probably children as well. And it's the reason that we have to make significant investments, as Dr. Maya said in her testimony, in every child-serving system so that we can identify those issues early and intervene with children at the earliest possible moment.
Dr. Amaya?
I would echo Dr. Evans' words and also thank you for thinking about these kinds of issues. What we're seeing, with children is multi-pronged. They're seeing, parents are scared, that makes them scared. They see parents fighting for what they perceive as right, they are going to fight as well. So there's a role modeling issue. But I also think, in these systems, whether it's, in schools, in activities, children need to know that they can be both psychologically safe as well as physically safe. And the fear is going to be a lot of what may be driving some of these, aggressive and emotionally dysregulated behaviors. And so I think where adults, counselors, teachers, can be given the opportunity to make sure that at all levels of the environment, in classrooms, on the playgrounds, in the halls at schools, that there's monitoring that can go on so that children can feel safe and psychologically, both physically and psychologically, I think will be a critical element.
Okay, thank you very much. I yield back, Madam Chair.
Congresswoman Barbara Lee.
Thank you very much, Madam Chair, and I want to thank all of our witnesses and for this very important hearing. It is so timely, Madam Chair. First of all, just for context, my professional background is clinical social work. Actually, my profession is as a trained psychotherapist. Now, in the 70s, I founded a community mental health center because we did not have any centers in the Bay Area that provided relevant, culturally appropriate mental health services for the African American community, for people of color. Now, this was in the 70s, and we had to develop treatment modalities. And the reason I founded this is because we did not have any treatment approaches that included the impacts of social determinants on African Americans and people of color. Racism, structural racism creates stress, creates trauma, creates physical illnesses, creates mental health illnesses, and all of what we're seeing now again, but also it creates early deaths. And so myself recently and Senator Warren and Congresswoman Presley, we introduced a bill, the Anti-Racism in Public Health bill, because it is so critical to address racism and structural racism, both individually and structurally, in our mental health systems. Because what you all have recognized and said is that this certainly has a terrible impact on the mental health of people of color, racism. And I think the rest of the country after January 6th really begins to understand how weighed down people of color are as it relates to white supremacy. So let me ask you, as we begin to fund our programs, understanding this context now in terms of structural racism, what would you suggest that we include and to disrupt, first of all, the systems that have been in place, and also to build upon systems that we know will address the specific stress as it relates to racism in people of color's daily lives? Because this is an issue that has got to be dealt with right away in this year's funding. And I want to see us put something in our bills to suggest that our programs have this incorporated. Dr. Evans,
Sure.
anyone could respond who can help us walk through this.
Sure. I think it's an excellent question. And I remember I did similar work when I was in private practice, creating models specifically for African American populations, because often African Americans have a hard time relating to more traditional services that didn't acknowledge their realities. I think that there are several things that you've said that I think are really critical. One of them is that I think it's important for clinicians to understand social context and understand those contextual issues. Often people are trained or not trained to acknowledge that. And it's one of the things that pushes people out of treatment. If people are seeking treatment and people are not acknowledging their reality, it's going to make it less likely for them to engage in treatment. From a policy standpoint, I think that there are several things that we need to do. One of them is to make sure that we are collecting the data and we're disaggregating the data. One of the big challenges we have is that we don't really understand. For example, when I was commissioner, we not only collected data, but we would geomap that data to look at where people lived and where the services were. And one of the things that explained people not getting to services was not so much that they didn't want the services, but the services weren't in places where they could easily access them. So we have to have that kind of data in order to make sure that people have access. And we have to make sure that we have specific data or specific funding for populations who we know are at greater risk and who are underserved. Generic services are important, but often generic services don't get at those unique issues that you have to overcome in order to reach specific populations. So I would strongly recommend that in terms of—
Dr. Evans, yeah, and let me just, few seconds I have left, on racism specifically, anti-racist policies. How do we get our mental health system to incorporate those? Because if we don't do that, people who are dealing with racism every day and the trauma that results will still walk around with that load on their shoulders?
Well, I mean, the research is pretty clear and it's consistent that racism does have an impact on people's mental health. I don't know that is a part of most clinicians' training. You're a clinical social worker, you probably know how much of that, social workers are actually better at that than most other mental health professions. But many of the mental health professionals don't have that understanding of that connection and understanding that we not only have to deal with people's symptomatology, we also, as a part of our training, have to help people with the realities in which they live in and helping them to actually navigate a life where they're experiencing those kinds of stressors.
Thank you very much, Madam Chair, and hopefully we can follow up and have some discussions about this. Thank you.
We certainly can in a number of these areas. I think we have the opportunity to do that with this subcommittee. Congressman Fleischman.
Thank you, Madam Chair and Ranking Member Cole. Again, another outstanding hearing for this subcommittee on an issue, mental health and substance abuse, that really has affected our nation pre-COVID and now currently. So thank you for holding this. The COVID-19 pandemic is having a significant impact on the behavioral health of Americans. A recent report found that symptoms of anxiety disorder are approximately 3 times higher, prevalence of depression about 4 times higher, overdoses are reportedly up almost 18% among adults compared to the same time last year. Even before the current public health emergency, the incidence of serious mental health illness had increased significantly from 2018 to 2019. Suicide rates have continued to increase, up 35% between 1999 and 2018. And drug overdose deaths have climbed to a record high again last year. The Mental Health Parity and Addiction Equity Act was enacted in 2008 and requires insurance coverage for mental health conditions, including substance use disorders, to be no more restrictive than insurance coverage for other medical conditions. Yet, the Medicare program limits beneficiaries to only 190 days of inpatient care in psychiatric hospital for their lifetime. People with serious mental illness may easily go over Medicare's 190-day limit during their lifetime, especially if they gain Medicare coverage at a younger age. When people with mental health illness cannot receive care in the right setting, they can end up in hospital emergency rooms, in jail, or sadly on the streets. My question is for Dr. Evans, sir. Do you believe Congress and CMS should reconsider the 190-day cap on inpatient psychiatric services? If so, what would that do for Medicare patient care, specifically in light of the COVID-19 pandemic? Dr. Evans, sir.
Absolutely, and I'm so glad that you're raising this issue. It's such a critical issue. People who have psychiatric illnesses need to have access to the services that they need, and we shouldn't place limitations, arbitrary limitations on people's access to that care. It is plainly discriminatory. We don't do this for other illnesses. We don't say if you've been hospitalized for cardiovascular disease 190 days, you can't go in, you can't have access on the 191st day. But we do that for mental illnesses, and it's just discriminatory. We need to stop it. And we need to make sure that people have access to whatever level of care they need at that particular point. And one other point that I will make, one of the things that happens to people in mental health systems, because systems are so different around the country, that in some communities that don't have enough outpatient and other types of lower levels of services may in fact have more days than people in other parts of the country. So it's a double whammy for people who live in communities who have had inadequate access to mental health care. They may have maybe overutilization of those psychiatric bed days, and then they would then have this arbitrary limit on access to needed care later on in the course of their treatment.
Yes, sir, Doctor. Thank you again for your testimony, the testimony of the other witnesses. Madam Chair, in light of the fact that we've got votes and time considerations, I'm going to yield back the balance of my time. But again, thank you and Ranking Member Cole for having this great hearing. Appreciate it.
Thank you so much, Congressman Fleischman. I just, in any case, before this is concluded, I would love, as I said, Dr. Evans, Mr. Stringer, anyone else to deal with the issue of Medicaid expansion as well. I think that would be helpful for us to understand. And with that, let me recognize Congressman Pocan. And if people need to go to vote, please do. I'm going to go to do that. And Congresswoman Roybal Allard will take the chair while I go to vote. So thank you. Congressman Pocan.
Great. Thank you, Madam Chair. Thanks for the hearing and thanks for the witnesses. Trying to get to two different subjects if I can. Last year, I worked with Chairwoman DeLauro to include language in the fiscal year 21 omnibus bill that required HHS, Department of Labor and Treasury to ensure employer-based insurance coverage is in compliance with mental health parity laws. As you know, the law requires insurers to cover care for mental health and substance use disorders at the same level as other medical and surgical care services. Yet over a decade later, after the first law was passed, we've seen the prevalence of mental health issues and substance use disorders rapidly increase, and there are still insurers that are not compliant with the federal law. So my question, I guess, would be for Dr. Evans and possibly for Mr. Stringer. How has the lack of access to health or to insurance coverage impacted mental health care, and has it been exacerbated by the pandemic, or has access to telehealth coverage increased access to care?
Well, telehealth has absolutely increased, and I hope, as you've heard earlier, that we continue that. Access to healthcare is extremely important. And you know, when I was a clinician and I was a clinical director of a triage facility, the first question that we asked when we were trying to figure out where we needed to send someone was not what their diagnosis was. It wasn't the level of intensity of their care. The first question that we asked was, what insurance do they have, or whether they have insurance? Because that dictates where you can go in terms of your treatment services. So if people don't have, first of all, access to those services because they don't have health insurance, often people don't get the care that they need, and they end up having a lot of recidivism. But the other point around parity, I think, is very critical. What we know from the parity, our experience with parity, is that it's not just enough to have the laws. We also have to have the enforcement. And it's been very clear that over the last several years, since the Parity Acts were implemented, is that we have to up the enforcement of parity, and we have to hold insurers accountable to making sure that the full range of services that are available to people from a physical health side are also available on the mental health side, particularly rehabilitative services and services that allow people to step down and stay and maintain their care in the community.
Great, thank you, Dr. Evans. Mr. Stringer, do you have a brief comment? Because I do want to get to a second subject. You may be on mute.
I've only been doing this for a year now, so I apologize.
No
I'm a
worries.
slow learner. Yeah, I completely agree with the doctor. You know, it puzzles me a bit why there isn't parity naturally, because good mental health care means better physical care with fewer costs. And so it puzzles me. I was in this business back in the early 1980s when there were a lot of private psychiatric facilities around the country that were doing questionable things and making a lot of money. And I think that frightened the insurance companies, and they've really clamped down. And what's unfortunate today is that they're still living in the 1980s in that regard. We need that care. So
thank you very much. Appreciate it.
Yeah.
And then a question for Dr. Maya Jackson with the time I have left. The Trevor Project, a leading organization providing crisis intervention and suicide prevention services for LGBTQ community, has said that since the onset of COVID-19, the volume of youth reaching out to their crisis services program has significantly increased, nearly double the pre-COVID level, And as you know, LGBT youth are already 4 times greater at risk of things like suicide. I was just wondering, how do we ensure these kids have access to mental health services, especially for kids who don't feel safe in their own home? We're seeing that's almost 3 times the rate with COVID that LGBTQ youth are feeling not safe at home right now.
Thank you for that question. Well, we know that LGBTQ youth and adults have long been burdened by mental health concerns, from anxiety, depression, self-injury, suicidal thoughts and attempts. Like you said, they have higher rates of attempting suicide, and they also experience trauma at higher rates than their straight peers. And we know where we can intervene are going to be in these places where youth are experiencing bullying, traumatic forms of societal stigma, bias, and particularly the family rejection, which is very problematic often for them and makes their ability to cope with some of these other things less possible. And the other problem is that historically professionals have been less successful in really recognizing and meeting the needs of traumatized LGBTQ youth that perpetuates many of their traumatic experiences. So I think that the issue is making sure that our providers and our child serving systems, yet again, are in recognition of this group as a high-risk, vulnerable population who needs access to evidence-based treatment, and that they need training in their ability to work and engage with these youth, and to get the conversations going with youth so that they know that it's okay and that they can feel safe in accessing care and getting into care where they can heal.
Thank you, Madam Chair. I yield back.
Okay, Ms. Herrera Butler. Ms. Herrera Butler? I'm going to then go to Ms. Clark.
Thank you so much, Chairwoman Roybal Allard, and thank you for this hearing. This is incredibly helpful and just a topic of such importance to my constituents back home. I wanted to ask about sort of the collision of 2 crises that we're seeing, that of racism in mental health and how the impact it has, and an impact on access to treatment, and also the rising overdose deaths. And my specific question is about Black patients with opioid use disorder. There have been studies that show they are 35 times less likely than white patients to be prescribed medication-assisted treatments that could help prevent relapses and deadly overdoses. What can we do as policymakers to combat the inequitable treatment of addiction in communities that are already dying at disproportionate rates from the pandemic? Sort of open it to anyone who might want to.
Well, in Missouri, we have put together a task force in St. Louis, in North St. Louis, which is really our hotspot for overdose deaths among African Americans, and in particular males. So we put together a task force that's looking at that. And one thing we've learned and should have known a long time ago is that the traditional treatment model of having a bricks and mortar building where people go and something mysterious happens and you come out and you're supposedly cured, you got a gold coin and all that model does not work. It just does not work with most in those kinds of areas. There are transportation problems. There's a certain amount of stigma, of course, associated with getting substance use disorder treatment, and African American people. And I hate painting any group with a broad brush, but generally, historically, African American folks have been distrustful of the healthcare system. I think that's a fair statement. And so we need to take treatment to them. We need to make sure that it's the kind of treatment that they would welcome. The message needs to be delivered by people that they trust. So we've engaged a large group of clergy men and women in St. Louis to help us reach into that community. So we are doing everything that we can and using the evidence that we have, and I'm optimistic that we're going to make a difference.
Thank you. And along those lines, Mr. Stringer, you know, before the pandemic, we knew there were estimated 120 million people who lived in areas without adequate access to mental health care. The vast majority are people of color and rural communities. Can you elaborate a little bit on how we can target federal support to help state and local public health officials like yourself in getting mental health care out to underserved communities?
You know, it's an interesting question. My interest and approach is, again, in taking treatment to individuals. And it's different how you take treatment to somebody in North St. Louis compared to how you take treatment to somebody in Northeast Missouri and in a very rural area. So, you know, the technology that we're enjoying now during the pandemic, and it's really having a big effect. If we can keep that technology, that allows us to take treatment out into rural areas. That to me is the answer. And then again, in inner cities, it probably is more of a taking treatment in person to people with mobile vans and things like that, mobile treatment sites, so that again we're taking treatment to individuals and families.
Thank you for that. And my last question is going back to as we are coming into a new administration, looking once again at disparate school discipline policies and the impact of behavioral mental health conditions, especially on Black and Brown youth, are that we know are more likely to be funneled into the juvenile justice system than to be provided mental health services. How can we work together going forward to make sure that we are giving every young person, every child that access? And do you think that we can work with these school discipline policies to have a true impact?
I'll jump in if anyone else doesn't. I think it's a really important question. So in addition to making sure that there are services in schools, we have to look at school discipline policies. The data are pretty clear that African-American children, both girls and boys, a new study has come out looking at the suspension rate for girls who are being expelled from school, African-American girls, is very significant. And so we can't talk about trying to protect people's mental health and not dealing with the reality of the disproportionate and often disparate discipline treatment. And so those two things go hand in hand. And I think if we really want to address children's social and emotional health, we have to look at those kinds of issues as well.
Thank you so much. I see my time has expired. Thank you for your indulgence, Madam Chairwoman.
Ms. Frankel.
Oh.
Ms. Frankel?
Hello, is that me? Me? Hi. Oh, it is someone very talking loud. Hold on. Thank you for this. Thank you, everybody. This has been quite a challenge trying to do this on my cell phone. Okay. So, you know what? I think, Mr. Evans, I don't know, is it Mr. Evans? Is that correct? Okay. This is going to sound like a simpleton question, but what's the opposite of evidence-based treatment? Could you just give an example of what's evidence-based treatment versus what is not?
Well, I would hope that we're not doing the opposite of evidence-based in our treatment. Really, what evidence-based practices recognize is that in most fields, including the behavioral health field, there's a gap between what the science says, where the state of the art is in the science, and what is actually widely practiced in the field. And that gap is about 17 to 20 years. And over the last, I would say, 2 decades, our field has been really trying to close that gap. And for example, when I was commissioner, we created an evidence-based practice and innovation center. We spent about $2 million a year trying to train providers in what the state of the art was so that they were practicing at the top of where the science is. So I think we're getting better at that as a field, but I will tell you it is very, very complicated and complex. And there are a range of issues from the infrastructure within treatment programs to financing issues to how people are trained. And you have to deal with all of those issues if you want to increase practice and get more people using those evidence-based treatment approaches.
Can you give me an example of like an old treatment that would no longer be not be considered evidence-based?
Well, a good one from substance use is that when I came into the field, we had very confrontational approaches to substance use treatment. So you're kind of in people's face, you were confronting them, and that helped some people, but it also was not very effective, and especially given what we know about trauma and the re-traumatization of people, it's a very good example of a practice that was widely practice, an intervention that was widely practiced. But with our new understanding of trauma and the fact that so many people who come into substance abuse treatment, particularly women, probably 80 to 90% of the women who are in our treatment programs, our substance use treatment programs, have some form of trauma in their history. And so that kind of confrontational approach can work against us and against them.
So, Mr. Evans, anybody else on the panel, how can give recommendations on how we in Congress can influence the evidence-based treatment rather than what would be, it seems, treatment that, you know, I won't use it old-fashioned, but it seems like it doesn't really work. What can we do at our end?
Sure. So, you know, in my experience, it really takes resources. We can't assume that simply saying, do this evidence-based practice is going to lead to practice change. And in fact, it takes a lot of effort to change traditional treatment approaches. So there are a couple of things that I would recommend. One thing that I would recommend that we not do is mandate particular evidence-based practices or even mandate a percentage of the evidence-based practices. What is more helpful is to have guidelines and then to have resources that systems administrators, people who are running mental health systems, can use to provide the technical assistance to treatment providers. In my experience, we were able to literally train thousands of workers, of mental health clinicians, and change practice in dozens of mental health and substance use programs by using that approach. Much more effective than simply saying, do this practice. Most of the time, providers don't have the wherewithal or the resources to actually be successful at that approach.
And are those guidelines being presented now, and by what entity?
They're not really presented as guidelines. I think to too great an extent that providers are left to try to figure this stuff out. If you're in a system where you don't have leadership by the systems administrators to guide people and provide the support, it is very difficult. For example, one of the things that I did as a payer is we paid providers to train their staff. So if you're in a highly fee-for-service system, as many systems that are highly reliant on Medicaid are, if they take their staff off to get the appropriate amount of training, they lose revenue. So that's a disincentive to actually do it. So you have to understand how the financing works to make those kinds of issues a non-issue so that providers can then focus on getting their clinicians trained up in the appropriate amount of time that's needed to get them to practice at the appropriate level.
Thank you very much. I'm going to follow up with you on this. And Madam Chair, I yield back. Thank you very much.
Thank you. I'm back, and I want to thank Congressman Roy Ballard, as now recognized Congresswoman Bonnie Watson Coleman.
Thank you, Chairwoman. Thank you for this hearing. I think I want to ask Dr. Evans some questions, particularly concerning the issue of mental health and the African American community. Before we had this pandemic, the African American community already had a pandemic. I did some work with mental health and suicide. It was with Black youth. I did some work on an emergency task force. So I was just struck by the range of ages that were caught up in that. I'm also concerned about just access to mental health services for African Americans in general. For instance, what is it that we need to do to ensure that there is safety when an African American is going through a mental health crisis and they're reached and the police respond to their door? What is it we need to do to make sure to ensure that there's greater safety when the police encounter a Black person going through a mental health crisis? What should we be thinking about doing here?
Sure. We have to train police. When I was a commissioner, we trained in Philadelphia. We trained about 40% of the police in the city during my tenure. And I and the police commissioner had a very close working relationship. The people, officers going through training got mental health training during the academy. And then when they were on the street for a certain period of time, they would get what's called crisis intervention training. Made a huge difference. When I became commissioner, we were having on a regular basis citizens being shot and often sometimes killed by police who were responding and didn't know how to respond to those issues. And I can tell you during the last several years, probably 6 or 7 years of my tenure, we didn't have one police shooting of a person who had serious mental illness. So it tells us that the training does make a difference.
So that's a best practice. Is that being shared with other states and municipalities?
A lot of cities are doing it. It originated in Memphis, Tennessee, but many states, cities are doing it. I think it just should be a standard. It makes a huge difference in the safety of the community.
Do you agree that there's a tremendous under-resourcing of Black clinicians, social workers, psychologists? Do you have recommendations for us in how we can encourage more and support more going into the fields that'll be more helpful in dealing with our communities with trusted voices? And why are they not going into those fields now?
Well, yeah, absolutely. And a big part of it is just financing and getting through the graduate school. So the Minority Fellowship Program is extremely important. That's a program that we really ought to be making significant investments in now, particularly now, because it's going to take some time for people to get through the pipeline. So, we should be looking at a doubling or tripling of the Minority Fellowship Program. One of the other things is that we have to break down the understanding of mental health issues. We have to deal with issues like trauma. In my tenure in working in the field, we spent time doing community events where people talked about mental health issues. Sometimes it was storytelling events that were things that people would be more likely to go to than a lecture, quote unquote, on mental health, or doing community art projects that gave us an opportunity to engage the community. These issues, we have to come at them in multiple ways. Part of it is working with the community to help change attitudes, and then part of it is making systemic changes like increasing.
I don't want to cut you off, but I have so much more to ask. And I do have a bill out right now that passed the last Congress, hopefully passed this Congress, redoubling these efforts to get more practitioners or providers in the pipeline. I'm concerned about our kids. I'm concerned about how do we deal with the trauma of the pandemic, the trauma of the isolation, getting back to what the heck is ever going to be normal again. Having our children not fearing being treated disparagingly in the educational system or with the law enforcement. What are all the things that we need to be doing? Are there best practices on getting schools ready, educators ready to deal and looking for the signs of trauma, et cetera? What should we be doing? And I know that this is expired time, but
yeah, I'll just say very quickly, we have to increase the mental health literacy of the population and of all of the people who are in child serving systems. So child protection systems, the school systems, we need to make sure that all of those professionals have a basic understanding of the signs and symptoms of having mental health problems and know what to do when people experience that. Additionally, we need to make sure that we're doing the same thing for parents, and we need to make sure that we're having these kind of conversations that destigmatize and normalize conversations about mental health in the African American community.
Thank you. There's so much more I'd like to ask, but my time is up.
Yeah, thank you for your
Thank you, Madam Chairman.
Yes.
Thank you. Congresswoman Herrera Butler.
Madam Chair, am I next?
Get Congresswoman Herrera Butler.
Hi, thank you, Madam Chair. The CDC announced that there was a surge in overdose deaths in the US. Over 81,000 drug overdose deaths occurred in the US in the 12 months ending in May of 2020, it was the highest number of overdose deaths ever recorded in a 12-month period, which is hard to believe. In my home state, in Washington, there was a 38% increase from the previous year, with fentanyl-involved deaths more than doubling. And this subcommittee has taken steps to try and curb the scourge that synthetic opioids have made in our communities, and these numbers continue to be concerning. So, Mr. Stringer, in your testimony, you mentioned that it would be more efficient to quote, transition over time from opioid-specific resources to invest funds in the Substance Abuse Prevention and Treatment Block Grant. Could you maybe explain for me this point further and how this transition would be helpful to your agency's response to this crisis during the pandemic and then after?
Sure. Thank you for the question. It's a very good one. You know, the drug landscape is always changing, as you know. I mean, you know, it'll be stimulants for a while, opioids for a while. Alcohol, of course, is always way up there. And states are different. You know, we see patterns across the country that vary. And so transferring these grants over into the block grants that go through the state agencies allows us to be flexible in responding to those situations. You know, if these current opioid grants were shifted over to the block grant, I don't think I'd do anything different until we got a handle on the opioid crisis. But when we did, that would give me the option to shift some funds over to something else, whatever the drug du jour is. You know, the other thing is that also ensures quality. When we were talking about evidence-based practices before, where things get squirrely is where funds go to agencies that are not licensed or certified or accredited, and that we have no oversight over. That's where things get squirrely. And what Dr. Evans was talking about, you know, practices that are not evidence-based, that's where you find most of them. So that's a long-winded answer to your question, but it's a good one. Thank you.
Thank you. And I wanted to ask another question. And switching gears a little bit, before the pandemic, we knew that there were many vulnerable groups that were not receiving the care they needed. One group I focused on extensively are postpartum moms who are at risk of postpartum depression, anxiety, and substance use. We knew that 75% of maternal health issues go untreated. One study found that untreated perinatal mood and anxiety disorders cost $32,000 per mother and baby, adding up to $14.2 billion annually. So my question is, how has the federal funding been used to target groups of individuals that we knew were struggling even before the pandemic? And how can we build off what is working, and how can we give providers the flexibility they need to treat populations that may be deterred from seeking help due to stigma surrounding mental health and substance use disorders?
Well, certainly in Missouri, pregnant and postpartum women are just about our top priority population. So we get those folks into treatment as quickly as possible and keep them as long as necessary until they're solidly into recovery. So I think making them a priority is important. And they are, by the way, a priority of the block grant. So that helps. And then Medicaid is an interesting situation because Medicaid coverage stops, at least in Missouri, after 60 days after birth. And gosh, that's not, if you're just now getting into treatment, that's not nearly enough time.
On that point, I'm supportive of a bipartisan piece of legislation. I believe we voted on in the House and didn't get all the way through to extend that Medicaid coverage for at least that first year, because we know that like 60 to 70% of problems occur in that year-long time. I mean, that whole year is postpartum, so we could go a long way in treating those women if we don't kick them right off of Medicaid within a month. Like if all my problems with having a baby came just in that month, that'd be great, but that's just not reality.
Yeah, I completely agree.
Thank you very much. Madam Chair, I yield back.
Let me see, Congresswoman Bustos.
All righty, thank you, Madam Chair. I appreciate you holding this hearing. Dr. Evans, this question's for you. I'd like to ask you about crisis care funding. Last session of Congress, I introduced a bill called the Crisis Improvement and Suicide Prevention Act. It's legislation that directs 5% of the $750 million in the mental health block grant to be used for crisis care services. I know you know this, crisis funding helps mental health providers all over the country. Specifically in my district, we have Rosecrance in Rockford, the Robert Young Center for Community Mental Health in the Quad Cities where I live, and Unity Place in Peoria, Illinois. And it funds crisis call centers and mobile units to travel to patients who are in crisis. I want to thank you for endorsing the legislation that we wrote out of our office. And I also want to thank Chairwoman DeLauro for passing this set aside into law in last year's funding bill. My question is this: how important is crisis care funding during and after? Because I think we can start looking a little bit ahead, cross our fingers, but during and after the COVID-19 pandemic. And then how much funding do you think we should provide the crisis care set aside as we move forward?
Yeah. So yeah, first of all, thank you for your support for these services, which are really essential in the community. I recently had a personal situation where I was helping a family friend access services. And what happens for mental health conditions, unfortunately, is that mental health systems are different in every community. And so it's very hard to figure out where you go for help, how do you get access to help. And I think what this funding does is it provides really a floor for mental health systems to make sure that they have the minimum kind of services in place so that when people are in crisis, they can reach out, they know how to reach out, and they can get help. So I think it's very essential. I also think that it's important to think about what comes before and what comes after crisis services. And to me, as someone who's run mental health systems who ran mental health systems for many years, that is as critical as the crisis services themselves. Often there are not enough alternatives to crisis. Many of the people who end up in crisis services are there because there simply is no other alternative. I know people, for example, who will go to an emergency department and say that they are suicidal just to get help for their substance use issue or for their mental health issue. And then on the back end of crisis services, we want to make sure that people have available services, because what happens is if people go into a crisis service, they get admitted to a psychiatric facility, and there's no aftercare immediately when that person discharges, it significantly increases the likelihood that that person is going to recidivate. And so crisis services are essential. We need to have a basic way that everyone can access those services when they need them, but we also need to make sure that we have alternatives, and we also need to make sure that we have continuity of care so that people don't have to get into that cycle.
All right, Dr. Evans, follow-up question for you. The National Institute of Mental Health says that more than 60% of rural Americans live in mental health and professional shortage areas. Rural America is my district. It is mostly rural geographically. And so just as an example, we have 14 counties in the congressional district I serve. 9 of the 14 are considered mental health shortage areas. Stevenson County, Joe Davis, Carroll, Whiteside, Henry, Henderson, Warren, Knox, and Fulton are all rural, and there's a shortage there. That's why in the December funding bill, I was lucky enough to be able to include language that encouraged Health and Human Services to increase the behavioral health workforce education and training program presence in rural areas. And I also introduced something called the Rural America Health Corps Act that supports 5 years of loan forgiveness through the National Health Service Corps for providers who commit to serve in rural areas. How else do you think we ought to be working with Health and Human Services to combat mental health provider shortages in rural areas besides what I just mentioned to you?
Great. I'm so glad you asked this question. This is a high priority for the American Psychological Association. We've been working with organizations like Farm Aid and other organizations to look at ways that we can help get more providers in those areas. The loan forgiveness is very important, but it's also important to fund and make sure that we have Medicaid expansion. And the reason is, and particularly in rural communities, and you would know this, is that hospitals often are strained by the number of people who have who are uninsured, uncompensated care. When those hospitals go away, often there is no behavioral health care provider in those communities. So we have to look at making sure that the individual is also covered and that their services are going to be covered in the providers that are in those communities. And we also need to make sure that we train providers to work in rural communities because there are unique issues. Farmers, for example, have a suicide rate that is significantly higher than the rest of the population. They have unique issues, and generic mental health services often aren't responsive to the unique strategies or the unique issues that those individuals are facing. And so we need to have a range of strategies to make sure that we shore up those services and that those services are appropriate for the people in those communities.
Dr. Evans, thank you very much, especially for your grasp of these issues that are so important. Madam Chair, I yield back.
Thank you. Thank you. Congressman Klein.
Thank you, Madam Chair. I want to thank the witnesses for participating today. I'm particularly concerned about the impact that the lag of our local school divisions in reopening following CDC guidelines to reopen is having on our children, on their mental health. Participating in school activities, whether it's school time, social time with their peers, engagement with the arts, musical performances, sporting events, routine activities, these have all been drastically altered or prohibited for in-person participation, and these types of activities play just as important of a role as the academic in-classroom experience, affecting our children's mental health. So while it's important to take public health recommendations seriously to stop the spread of COVID, we must take a critical look at what common sense precautions we can incorporate into these activities so that our youth can get back to normal. The Virginia chapter of the American Academy of Pediatrics completed a survey recently, and 97% of respondents said they had either seen child and adolescent anxiety increase or greatly increase since the pandemic. And a majority responded saying they had also seen a change in depression levels, with 95% saying it had either increased or greatly increased. A report by the Centers for Disease Control and Prevention showed an increase of 31% in children's visits to emergency departments for mental health concerns for those ages 12 to 17, and 24% for those ages 5 to 11 over last year's numbers. I'm encouraged to see the topic of mental health discussed more openly, removing the stigma that surrounds this issue, but there's much work to be done. So I'll ask Dr. Evans. I recently was in touch with our governor in Virginia, who has put through a particularly stringent shutdown and is lagging on reopening and following CDC guidelines, particularly when it comes to youth sporting events. The governor has only capped at 250 participants, or a 20 or 30% capacity rate for attendance, encouraging people to remain 10 feet apart at these events and masked, which is far beyond what is recommended. So Dr. Evans, you stated that prolonged social isolation due to the pandemic has placed inordinate stress on many interpersonal and familial relationships and threatened normal child development, which is dependent on interaction with peers and others. You also said that children's mental health is particularly vulnerable. Can you elaborate on how activities like attending a local sporting event, being in the band, or a cheerleader can impact students?
Sure. So we know from a lot of research, decades of research, the negative impact that social isolation can have on our mental health. I think in addition, for children, we have to be aware of not only the stressors that they're experiencing, but they're also missing important developmental milestones that are important in our development as people. And for children, I think we have to be concerned about two broad areas. One is the mental health that we're talking about today, but we also have to be concerned about cognitive development, disruptions in learning, and the long-term impacts that's going to have. So I think the implication of all of this is, yes, there are things that we have to do in terms of protecting our physical health, but the points that you're making about the impacts on our mental health are really critical, and we're going to see these impacts over a number of years, not months, once the pandemic is over. And that really means that we have to have the resources there to address both of those sets of issues.
Thank you. Another area that I'm concerned about is the increase in domestic violence and the impact of domestic violence on children. As a former prosecutor of domestic violence, I understand the importance of ensuring that victims are taken care of, and the pandemic has only made it harder. Isolation is a major risk factor in intimate partner violence and family violence. Unfortunately, isolation as a result of the pandemic may have exacerbated domestic violence cases. So, Dr. Amaya Jackson, you discussed in your testimony how the economic and other strains caused by the pandemic increased that risk for family violence. Can you expand on the factors that are contributing to this increase and ways that we can address that and help them get to resources?
Sure. Yeah. Thank you for that really important note and question. So, children and families, when there's overcrowding, they're in quarantine, they're isolated, they're not having the social support. These are the things that create tensions and conflicts and often lead to violence, particularly where families already have pre-existing scenarios where there's been tension, job insecurity, potentially poor relationships in the past, and it ends up being a powder keg, and children are exposed to this violence, and families are experiencing this violence. The next steps of what we can do is really going to be making sure that community supports, that we have training to providers so that people are accessing can be willing to bring these concerns to their community physicians, to their therapists, so that the therapists can address these issues, that the communities have the support, and that there's a trauma-informed system in place to handle these situations.
Thank you. I yield back.
Congresswoman Lawrence.
Thank you so much, Madam Chair. I want to talk about an issue that is extremely important to me, and that's our foster children. The American Academy of Pediatrics and the Healthy Foster Care American Initiative identified mental health as the greatest unmet health need for children and teens in foster care. I have a bill that requires that we, who are the custodian of these foster children, that we mandate that these children get mental health, just like we mandate they get physical health screenings. Dr. Evans, can you explain why it's so important that we address these mental health needs of our children, especially those who are likely to experience trauma? I take in foster children every year as an intern in my office, and one of them told me the fact that I'm in foster care means I've had a trauma in my life. Why are we as a government not stepping up? Could you please add your feelings on this issue?
Sure. Thank you so much. And I feel strongly about this because I work both in the child welfare system as a commissioner and then as a commissioner in the mental health system. And, the young person is exactly right. You can assume that every child who's in the foster care system has experienced some kind of trauma. Minimally, they've been removed from their families. And one of the things that people don't understand is that removing a child from their family, even when there may be neglect involved, can be just as traumatic and sometimes more traumatic than whatever the issues are that may have led them to be involved in the child welfare system. I believe strongly that we have to take a multi-systemic approach to this issue. Implementing programs like therapeutic foster care, making sure that every foster care parent has some basic understanding of mental health issues. They know how to connect their child to those services, and that the child protection system has adequate resources to make sure that those services are available to not only the child, but to the child and their family. You also have to educate judges. One of the things that we did when I was commissioner was to work very closely with the judges to make sure that they were making good decisions about how to place children and what were the services that the children needed. And so you have to work in sort of multiple levels. You have to work with the court system to make sure that they're sensitized to the issues and that they're making trauma-informed decisions. You have to do that in the mental health system. You cannot assume that just because a person is trained in mental health, they understand the unique needs and issues related to children who are in that system. And you have to make sure that the people in the child welfare system are getting the training that they need so that they're making good decisions in terms of how those children are treated.
Hello, Dr. Jackson, can you please respond to this as well? Because the things that was just touched upon, our legal system, who has a major role in this, and also the parent. Do you have any comments on this foster care crisis I feel that we have in America with mental health?
Yes, again, thank you for that question. So it's multifold, right? It's the experiences of the children that become cumulative over time and lead to complexities in their behaviors and their emotions and their cognitive functions, whatever, that makes it difficult for both child-serving providers and the families that are working with them, to handle that. And so it's how do we increase the capacities of, foster parents, kinship parents, et cetera, to be better able to take care of these children, to make them feel psychologically safe as well as physically safe. And the NCTSN does have programs and trainings. We have developed full-on curricula called the Resource Parent Curriculum that works with foster parents so that they can understand, when the children are waking up crying and having nightmares about blood or something like that, that they know what to do and how to handle that, how they talk to these children. So there's the issues that deal with it directly with the children and helping the foster system and the child-serving providers to be ready and able to work with children with these kinds of difficulties. But the other issue, which Dr. Evans alluded to, is making sure that child welfare system is trauma-informed. And what I mean by that is that these these systems know how to screen for trauma exposure and related systems. They know how to make resources available to them that are, on trauma exposure and its impact in treatment, and really engage in efforts to strengthen the resiliency and protective factors, and working with these families and the entire system, from the front door that you walk into a child welfare program to the way the caseworkers are dealing with them. And the caseworkers themselves are often very overwhelmed as the numbers increase.
Yes.
Dr. Evans was alluding to this. They often have secondary traumatic stress reactions themselves. So the whole system really has to be addressed to help that be trauma informed as well.
Thank you so much, and I yield back.
Congressman Harder.
Wonderful. Well, thank you so much, Chairwoman DeLauro, Ranking Member Cole, for hosting this hearing on this incredibly important topic, and thank you to the witnesses for contributing their testimonies. I've discussed provider shortages before, and I know Congresswoman Bustos touched on some of the challenges that our districts actually share in rural areas. But I think the mental health shortage is just incredibly acute. I mean, for every 5 mental health practitioners per 100,000 people that there are in California, there's only 3 in my district. It's close to half where we have in sort of 4 providers per capita. And obviously that's gotten worse during this pandemic, as my district has seen increases in mental health needs for many of our constituents, especially the students and family members that we've been talking about during this hearing. And I think that really is a profound statement of sort of our values in being able to deliver a very appropriate and effective mental health treatment in rural areas. Mr. Stringer, I'm very curious, with your experience, given that you oversee Missouri's Department of Public Health, can you provide some examples with how you or other state departments have succeeded in the long-term attraction and retention of mental health providers, and what do you think should be done by this committee to continue to bring that to the next level?
Yeah, thanks for the question. I wish I had a good answer. We have done some things to make the situation better. One example is we have a critical shortage of child psychiatrists in Missouri and around the country. So we worked with the University of Missouri-Columbia to develop what's called the Child Psychiatry Access Program, where physicians across the state can sign up for this, and so a pediatrician who's got a behavioral health problem in his office in Northwest Missouri can call and be on a phone or a WebEx with a child psychiatrist at the University of Missouri for consultation. That's a nice model, and it's a great way to spread our child psychiatrists. And I think it's things like that. There are ECHO training programs that are helpful. It's just going to involve multiple things. And in terms of the committee, you've already been really good about educational reimbursement and things like that. And I think we've got to take a multifaceted approach to this. A part of it is certainly helping kids with tuition and things like that.
Well, thank you. Well, I appreciate that. Well, one of the models that we have seen been very successful for mental health in our area is the Promotora de Salud program, which is essentially community health workers targeted towards our Latino community. Oftentimes that's the front line of attack against some of the mental health challenges that we've seen, especially in this pandemic. I'm curious where folks have seen that model been successful, and whether or not what opportunities we might have to continue to scale up those sorts of community health workers, especially in communities of color, to make sure that we can cater to the mental health needs in a real community-centered approach. I don't know if that's for anybody on any of our witnesses that have any suggestions around that.
In Missouri, we have certified peer specialists, which is that's a big part of the answer to the workforce shortage, and that can be done fairly quickly. We have certified peer specialists that work with our professionals. These peer specialists are people who have had some training and they have lived experience with a mental illness or a substance use disorder, and they work hand in hand with our mental health professionals, and they will go into emergency rooms, for example. They'll go into a variety of community settings for the purpose of outreaching and engaging people in services.
Terrific. Any other witnesses have any suggestions on provider shortages in general or that type of community health worker model?
Well, I think what I would add to what Mr. Stringer said is that there is a move in the mental health field to do what's called task shifting. There are things that we do in the mental health world that don't necessarily need a person who's trained at the master's or doctoral level. And as the program, not familiar with that specific program, but that it sounds like that program is taking people who may not have the higher levels of training, but might be very effective at engaging people. So I think that those kinds of strategies and peer services, as you heard Mr. Stringer talk about, are really critical. I also think that telehealth is extremely important, and audio telehealth, particularly in rural communities and frontier communities, which we often don't talk about, where people don't have the broadband bandwidth to do regular telehealth. So making sure that audio telehealth and telehealth in general is available is a really important aspect to addressing the shortage.
Perfect. Well, thank you, Mr. Evans. Back to you, Madam Chair, and thank you so much for your time.
Thank our witnesses. We will not have a second round of questioning, but let me ask of Congressman Cole for any last minute thoughts or comments or a question that you might want to ask.
Well, I'll try to wrap up from my standpoint. First of all, thank you, Madam Chair, for the hearing. I think it's clearly a subject that the committee cared very deeply about. We had a lot of great questions and observations, comments. I want to thank our witnesses. Also want to apologize to them a little bit. We all had to go in and out voting, but that's what they pay us to do up here. So I'm sure you're going to be generous in forgiveness in that regard. I'm struck, Madam Chair, as you were, with number one, the consistency of thinking from a variety of perspectives in this particular panel. I'm struck too, just thinking over several hearings about the things that we see over and over again, the disparate healthcare outcomes, the workforce shortages in a variety of areas. It strikes me that we do a very good job in probably taking care of the research into this, and maybe not as good a job in just the delivery and the coverage area. We all know we've got tremendous problems in terms of matching up our workforce with our needs and having a workforce diverse enough that it matches with our population. Just a lot of serious issues here that are going to take sustained investment over a lot of years. But that may be that. Well, let me put it this way: this pandemic is certainly going to cast a long shadow. It's not a situation where we've got the vaccines and, gosh, in 90 days we can look in the rearview mirror and put this behind us. I think the panel made very, very clear the consequences of this are going to live a long time and affect a lot of individual Americans in very negative ways. And we're going to have to think that through as we try to manage expanded but still always limited resources to cover these gaps. But again, I'll just thank our witnesses. You were all terrific and very, very helpful in highlighting the areas that this committee needs to take into account and focus on in a bipartisan way and move forward. So with that, Madam Chair, I yield back to you.
I want to thank the ranking member for his comments and cooperation in the past on these issues. And I know we'll have a cooperation going forward in these areas. And I too want to say thank you to all of the witnesses who joined today. And again, it's really, you're laying out a blueprint for us. And we need to be mindful of that blueprint and look, as the ranking member said, within the scope of the resources, et cetera, really to deal with how we are going to prioritize this area going forward, because this is not just for the moment, short term, and it's important. And you've elucidated, which I will mention, on some of the short term things that we can do, but this is going to be post this pandemic and what we are going to live with. And I say that because we know, and why today was so critically important, we have studies of Chernobyl, Hurricane Katrina, September 11th, to show that elevated rates of mental health problems go beyond the initial event and sometimes last for more than a decade or beyond. And this virus has the same similar long-term disaster. And what you have laid out and what people are dealing with is anxiety, depression, grief, isolation, and what that has already translated into an overdose, death, people thinking about suicide. So I think the emergency, which we recognize, I want witnesses to know that we recognize the urgency of the action that we need to take if we want to make an impact. And we also know that we had a system that was already struggling with trying to meet the existing needs of mental health. And it wasn't front and center. But in so many ways, what this pandemic has done is to really expose the shortcomings in our various systems, whether it be unemployment insurance or public health infrastructure, healthcare disparities. All of these have been, just really exposed and exacerbated because of the pandemic. So how we deal with improving the pipeline of providers and how we look at the services. And I do want to mention this to you because as listen to this, just it pulled out some of the, to our ranking member, most of these issues fall within the bailiwick of this committee. It's the population health approach, which Dr. Evans spoke about, working with communities to identify someone with a problem before it becomes a crisis and look at it in terms of populations that we know may be potentially at risk. We're talking about African-American communities, underserved communities. Congresswoman Roybal Allard talked about postpartum moms, et cetera, in a number of areas. So which part of the population and how do we deal with that? And it is not cookie cutter. Increased funding for school-based mental health. Increased access to evidence-based trauma-informed care. And we need to hear from all of you about best practices on trauma-enforced training. Help us with that so we put the money in the right places in this issue. Resources, and you've been consistent on the substance abuse prevention and treatment block grant program, which is something that you all believe is a direction that we need to go in. Funding for workforce programs to address the provider shortage here, which is critical. Prioritizing the needs of at-risk, vulnerable groups, children and adults. That goes back to the population approach. Increased integration of mental and physical health. And I will tell you, because these are pieces that we are funding already and we need to take a hard look, is the certified community behavioral health clinics, which move us toward this goal. The National Center for Childhood Trauma and Stress. This is working, and we have put funds into these programs. And how we sustain or enable grantees to be able to sustain themselves with funding, important part of the long-term response. And looking at SAMHSA, at their role as a lead coordinating agency. So how do we reduce stigma on all of this? And it may be that, unfortunately, that this is such a widespread issue at the moment that the issue of stigma may be, lessened, how it's pointed out, because we are going to see this short-term and long-term, so people understand it. And one of the things I pay close attention to is we don't have, at least the data now shows that the suicide rates have not really increased. However, there's been an increase in people thinking about suicide. And as I understand it, and I'm not professional in this area, but it's after the event is over, we will see increased suicide as a result of what happened. It may not be happening now, but we are going to see that. So there are a number of these issues. There are a couple of them. The telemedicine issue, Medicare, Medicaid, as we've talked about, and Mr. Stringer, I know Missouri voted on it, but it has not yet been implemented. But everybody has alluded to Medicare and the Medicaid expansion of really being helpful, because then you can take resources and use them elsewhere, which is so critically important. But telemedicine, Medicare, Medicaid, it's not part of our jurisdiction, but we can certainly have, an impact on the committees and the subcommittees that do have that a jurisdiction. I can't thank you enough, really, for for what you do every single day. And what we want to do is to be partners with you. And I don't want the conversation to end after this hearing, but as we look toward the appropriations bill for 2022, we would like to be able to take advantage of your knowledge and expertise and where we place. The resources are not unlimited, but help us to identify where we can utilize our resources in the best way to address short-term, long-term, and use this as an opportunity to build some of the architecture in this area that we need to have for the future. So again, my thanks to all of you and to all the members of the subcommittee, and particularly to our ranking member for your interest in this area. We are going to move at it, and we're going to be in touch with all of you, but don't hesitate to be in touch with us as we go forward. Thank you so much. And with that, this hearing is adjourned. Thank you.